Assalamu alaikum. Welcome to the third and last day of 19th Shaukat Khanum Cancer Symposium. And I would like to thank all my participant panelists and the speakers. So the first talk of this session is update on soft tissue sarcomas and gastrointestinal stromal tumors. Dr. Abdulrazak Al-Beruni is a clinician investigator based at Princess Margaret Center and Mount Sinai Hospital, Toronto. Originally from Malaysia, he obtained his medical degree in Ireland under a scholarship. After completing general medicine residency, he completed oncology fellowship both in Ireland and in England, and then he undertook a drug development fellowship at Princess Margaret and transitioned into staff position in Canada with a focus on sarcoma and early drug developments. Dr. Razak has been the principal investigator and co-investigator in more than 80 clinical trials and has published over 100 journals. Currently, he is working as a staff physician at Princess Margaret Cancer Center. He is medical oncology sarcoma site lead, clinician investigator, and associate professor of medicine at University of Toronto. Thank you so much, Dr. Razak, and this is over to you. Please start your slide share and the talk.
So thank you very much. Assalamu alaikum and good morning, everyone. Today, I would like to share with you on updates with regards to soft tissue sarcoma and GIST. Can you see my slides now?
Yeah, we can see.
Perfect. So first and foremost, thank you for giving me this opportunity to speak in your program. I'm very delighted to share some time with you, and hopefully in the next 20 to 30 minutes, we can explore some of the new developments as it pertains to soft tissue sarcoma and GIST. So this is my disclosures. I receive research support from any pharmaceutical company, given the work that I do. I also have got some paid consultancy to myself, and I would also like to take the opportunity to give some slight credit to my previous mentors. So the presentation outlined today will focus on soft tissue sarcoma and GIST, and we will really have a look at systemic therapy in the metastatic setting. Given the time constraint, this would be our focus. And I would like to bring to you, in terms of soft tissue sarcoma and GIST, what's established therapy, recently approved agents, and hot treatment in trial space as it pertains to these diseases. So let's talk about soft tissue sarcoma and established therapy. So chemotherapy in metastatic soft tissue sarcoma hasn't really moved for the last 20 to 30 years, and doxorubicin remains our drug of choice. This is one of two drugs that has single agent activity of 15 to 20%, the other being ifosfamide, but that is even a more toxic drug in this setting. It remains the backbone therapy for soft tissue sarcoma, and we have repeated trials where combination chemotherapy regimens results in better response and performance of progression-free survival in some of the trials, but consistently not in overall survival. And this is true whether or not we use classical doxorubicin chemo combinations, non-doxorubicin chemo combinations, and targeted combo therapy or novel therapies together with adriamycin. And I'll just pause there, and I would like to show you some examples with regards to this. So with regards to dox plus another chemotherapy, classically the backbone of these trials would be doxorubicin and ifosfamide versus doxorubicin alone. And the latest of these type of approaches using classical doxorubicin and ifosfamide was indeed the EORTC 62012 study. And in this study, adult patients with metastatic disease with good performance status was either randomized to doxorubicin alone or in combination with ifosfamide. The primary endpoint for this study was overall survival, with secondary endpoints being progression-free survival, best response rate, and toxicity. And unfortunately, this is one of many trials where it shows that the overall survival is no different. So if you look at the Kaplan-Meier curve here, if you look at the overall survival benefit, this is actually quite small. And it fails to meet statistical significance with some superiority in median progression-free survival. And, unfortunately as well, combination has been shown to be much more toxic with, more frequent dose interruption, dose reductions, and so forth. And this is a type of study that has been repeatedly to be shown to be consistent in terms of findings. There is alterations to regimens like this. For example, there was a combination of ifosfamide and doxorubicin versus doxorubicin, and that's no better than what we have. If ifosfamide has also been used as substitution to ifosfamide, again, failing to find superiority in overall survival. So that's the dox plus chemo combination. So let's look at doxorubicin-based therapy. So a classical example of this would be a trial by the Brits and the Swiss, looking at gemcitabine and taxotere versus doxorubicin. Please note the dose of gemcitabine perhaps is lower than what we normally would like, which would be a criticism of this study. And this study was looking at primary endpoint of progression-free survival, with secondary endpoints as listed there. And quite disappointingly, despite the early phase 2 studies that were promising, the median progression-free survival or at attenuated time points, as well as median overall survival and then attenuated time points, failed to achieve a superiority numerically or statistically. And there was a question whether or not leiomyosarcoma seems to respond much better to this regimen. It does not seem so from this study. And this study has since been published since its original presentation back in ASCO around 2015. So what about targeted therapy, the latest of which, this is a study that we were quite heavily involved with in Canada. This was doxorubicin plus minus olaratumab for metastatic soft tissue sarcoma. And in this study, proceeding from a phase 2 study, which shows an astounding overall survival in a phase 2 setting, subsequently, we had patients that was put onto this study, which is randomized to doxorubicin or doxorubicin to plus olaratumab. And the difference here is that the olaratumab is given continuously, even post doxorubicin. But if you notice that doxorubicin was given more than what we standardly use, about 8 cycles instead of the usual 6. Unfortunately, the study has now been reported and it was a profoundly negative study. There was no overall survival benefit. There was no progression-free survival benefit. And even if you look at leiomyosarcoma versus non-leiomyosarcoma population, there was no real difference. Now, this approach has also been approached in other studies. For example, there was a study of doxorubicin and ifosfamide plus TH302, which is an anti-hypoxic agent, and that also failed to benefit. So we are still somewhat stuck in the first-line setting where doxorubicin single agent is still the drug of choice for many of our soft tissue sarcomas. The use of combination therapy is only warranted, at least in my opinion, where there is a need to induce a response, where if the tumor is near a critical organ or if there is a need to cyto-reduce the disease in order to produce symptomatic benefit. But it does come at a cost with regards to toxicity. Now, with regards to recently approved agents, there are some flavors to this. I couldn't possibly cover all the therapies that are approved, but I just wanted to give you examples for which I hope you'll appreciate where this field is moving. So one of the most important understanding in sarcomas is that we have been trying to treat this disease as one, and that is a futile attempt for many, many years. The last classification by WHO on soft tissue sarcomas published this year shows that soft tissue sarcoma is somewhat about 159 different subtypes and is fairly complex. They are cytologically, histologically, as well as genomically very different, and therefore it is naive for us to think that, you know, this is a disease that can be treated with one particular approach. So I think more and more understanding of this scientific differences have led us to have more focused clinical trials as we go along. So in terms of newer agents per se, you will see that, you know, we seem to concentrate on different subtypes of disease or population. Most inroads are in patient populations beyond doxorubicin treatment. So most of the newer approved agents mainly concentrates beyond doxorubicin at this time point. And we frequently use alternate endpoints such as progression-free survival instead of the classical overall survival endpoints. So this is an example of trabectedin versus dacarbazine. Trabectedin, as we know, is previously known as ET743, synthesized from a biomarine specimen. It's a toxic sea slug, if you like. And this is a drug that was approved in Canada and Europe based on a phase 2 study, but in the US, the FDA have mandated a phase 3 study, and it led to this international randomized open label study of trabectedin versus dacarbazine. And many of us would consider dacarbazine as a, you know, low-hanging fruit for a comparative arm in soft tissue sarcoma beyond doxorubicin. This is a study of primary and with a primary endpoint of overall survival, and patients were randomized to either trabectedin or dacarbazine in 2-to-1 fashion and treated till progression. This study did not show an overall survival benefit, so it did not meet its primary endpoint, but it did meet a secondary endpoint of median progression-free survival with a superiority of about 3 months and seems to be statistically significant. And if you look at the histologic subtype, who really benefits from this drug? Although these were studies that were limited to patients with either leiomyosarcoma or liposarcomas, the leiomyosarcoma patient seems to derive a benefit. Patients with myxoid or round cell sarcoma seems to derive a benefit, as well as pleomorphic sarcoma. But your classical dedifferentiated, well-differentiated sarcoma, perhaps the degree of magnitude is less, but still there. Based on this data, the FDA as well as Health Canada has approved this drug in the second or third line setting in liposarcoma and leiomyosarcoma. On the same vein, there is another drug that has been used. Those of us who treat breast cancer is very familiar with the drug eribulin. And in this study, eribulin was pitched against dacarbazine in the 2L sarcomas, i.e. liposarcoma and leiomyosarcomas. And again, they're treated till progression. The primary endpoint of this study is overall survival with a host of secondary endpoints. And what we saw here is that this study did, in terms of intention to treat, did induce a modest overall survival benefit without a progression-free survival benefit, but the benefit seems to be retained in the liposarcoma population, not leiomyosarcoma. Unfortunately, this came at a cost in terms of there were a lot more grade 3 treatment effects, but to my eyes, this is a reasonable compromise. Based on this data, this drug is now licensed as well in the use of soft tissue sarcoma in Europe as well as in North America. Targeted therapy has also made inroad, and unlike those two studies where they looked at very tight tissue subtypes, this particular study is against placebo first and foremost. The primary endpoints is progression-free survival. But what is interesting as well is that this study did eliminate liposarcomas given the lack of efficacy in this disease subtype in their earlier phase 2 studies. So liposarcoma patients were excluded. And again, patients were randomized 2-to-1 from with regards to pazopanib versus placebo. As the results go, it did show a progression-free survival, but it did not show an overall survival benefit. This is due to probably the fact that they had post-trial treatments that account for the lack of overall survival. It does come at a cost in terms of more side effects, namely GI side effects, hypertension, and things like skin and hair hypopigmentation. There are a number of people as well with increased liver toxicities, but this is considered fairly low. So I hope what I've shown you is that in terms of established therapy, doxorubicin remains king. In terms of recently approved agents, there is a flavor of these studies looking at newer treatments in terms of, first and foremost, in beyond doxorubicin, they seem to contain to specific populations. And many of the studies also look at alternate endpoints. And the regulatory bodies have actually given approval based on surrogate endpoints as opposed to the classical endpoint of overall survival. So let's look at hot treatment in trial space, so to speak, in soft tissue sarcoma. The first is a new agent that is called selective inhibitor of nuclear export. This is a drug that is used, or the scientific rationale of using this drug is retention of tumor suppressor proteins in the nucleus as opposed to the cytoplasm. We were actually the group that were involved in the phase 1 studies of these patients, where there was a lot of patients with sarcomas, especially liposarcomas, who benefited from this particular agent. And this led to a phase 2/phase 3 study of selinexor versus placebo with an endpoint of progression-free survival. This study was announced top-line results only this week with a reduction of progression-free survival of about 30%, meeting statistical significance. And I would invite you to watch the late-breaking abstract at CTOS this year, which shows the more detailed results. But this is an agent that is probably going to be filed for registration given due to the positive results in the population of liposarcoma. In the field of liposarcoma, we also know that MDM2 and CDK4 is highly amplified. There's a number of phase 2 trials using palbociclib and another study of abemaciclib showing activity of this agent within the liposarcoma space. So this is a study performed by Mark Dixon where a variety of patients had stable disease and response with the use of palbociclib. I do not have the slides of abemaciclib because this was just presented last year, and this shows again similar, if not slightly better results than palbociclib. So this is an area that's coming along. We did actually publish we were in the process of publishing a CDK4 plus MDM2 inhibitor. It's the first one globally in well-differentiated and de-differentiated liposarcoma, and you can see the results can be quite astounding. But this class of treatment will be severely hampered by the fact that it's highly myelotoxic, and we will need more thoughts into how to deliver this in a clinical setting where patients can tolerate it a lot better. Now, no talk would be complete without immunotherapy. Again, taking the vogue that we're looking to basket studies, the SARC-028 study, which was undertaken by a selected number of host institutions in the States, looked at advanced sarcomas. They actually have two separate populations, soft tissue and bone sarcomas. But for soft tissue sarcomas, they included patients with leiomyosarcoma, liposarcoma, UPS, and synovial sarcoma. And patients were treated with pembrolizumab, 200 milligrams IV every 3 weeks till progression. And what was interesting is that when we look at the soft tissue sarcoma patients, there were a number of undifferentiated pleomorphic sarcoma, UPS, as well as liposarcoma patients who benefited from this approach. These results have been updated and was presented by Melissa Burgess from Philadelphia last year to show that these figures still stand true. And you can see from the spider plot there, UPS and liposarcoma seems to be the group that benefits most, less so for leiomyosarcoma leiomyosarcoma and synovial sarcoma, which we now know is actually quite a cold tumor. So in the US, there is an alliance study of ipilimumab and nivo undergoing in soft tissue sarcoma. And we in Princess Margaret had the DAPA study, which looks at the combination of pembrolizumab, durvalumab versus durvalumab plus cediranib, or durvalumab versus plus olaparib in order to turn a cold tumor hot approach. And that data is about, hopefully will be presented at ASCO next year. So immunotherapy is again making small inroads. Immunotherapy has made a very big impact in the ASPS field. There was a phase 2 study that was conducted by Brilliant Wilkie, who's now in Colorado. She looked at pembrolizumab plus axitinib, and there were 12 ASPS patients, and the 3-month PFS for ASPS patients was some 73%, which was amazing. The NCI in the United States have also conducted a phase 2 study of single-agent atezolizumab in ASPS, and that's currently going. We have seen a lot of these patients within our early drug development group, and you can see astounding responses, such as depicted here, where this patient was, at the time of presentation, and those are the 2 pictures on your right. He was really on oxygen and given immunotherapy, still alive and well without much disease today. And that was about 5 years ago. One of my fellows, Jeremy Lewin, actually looked at why these patients benefited so much from immunotherapy, and we discovered there was a non-canonical mismatch repair aberration. You can see here from the blue graphs. These are not your classical MSI or MLH or PMS6 aberrations, but this is a non-canonical ones that is yet to be described completely. And our current fellow, Jeff Watson, is actually doing more work in this, looking at transcriptomics. So with regards to GIST, so I'm in the last 1 or 2 slides really, we all know imatinib, sunitinib, and regorafenib are the drugs of choice, and these are licensed. Once you move beyond first, second, and third line, first and foremost, there's nothing. Until recently, and there are spaces where there is gaps of therapy. A classical example will be PDGFRa D842V variation, which is about 5% of GIST patients, and these patients unfortunately don't respond to sunitinib. We also know when we move from first to second to third line therapy, the magnitude of benefit drops significantly. So the 2 gaps that we have filled recently is 4th line therapy, as well as treatment options for our PDGFRa D842V mutant GIST. Let's talk about recently approved agents. So 4th line therapy, Avapritinib, is now approved in 4th line setting. This is a drug that is a switch control TKI inhibiting KIT and PDGFR alpha kinase signaling. The phase 1 study, which is again carried out in our institution, shows that the dose is 150 milligrams once daily, but this can be escalated up to BID if needs be. And a phase 3 study trial of Avapritinib versus placebo, this is a 2-to-1 randomization, shows clear benefit in 4th line setting favoring Avapritinib, whether you look at progression-free survival or overall survival. This drug is now entering trial, which is nearly completed. We have only about 20 patients left to complete on the study, looking at Avapritinib versus sunitinib in 2nd line setting. Now, in terms of PDGFRa D842V study, there was a phase 1 study, and that study was called the Aviator study, and it completed with with over 56 patients, but 56 patients had the PDGFRa D842V mutation. And as you can see from the profound waterfall plot there, nearly every patient had a tumor reduction, many of which had partial response, and quite a few had a complete response. Now, just to put you into perspective, this was a disease where there was no real effective treatment. So based on the phase 1 study, this particular drug is now approved for the PDGFR mutant alpha patients. This compound unfortunately failed to meet its primary endpoint in all GIST patients when it is compared to regorafenib in third-line setting. The top-line results have come out. We are awaiting on a formal presentation with regards to this. So in summary, I hope in the last 20 minutes or so, I've shown to you that doxorubicin still remains the primary treatment in most soft tissue sarcoma. As we go along, histology-specific approach is becoming more important, and novel therapy, including targeted and immunotherapy approaches, are making inroads into this disease. With regards to GIST, we've got 2 new candidates, Avapritinib in fourth-line setting, and hopefully in second-line setting in the near future, and Avapritinib filling a huge void for PDGFRa D842V exon 18 mutations in GIST. Now, I'd like to say thank you to the sponsors of the meeting, but I also would like to highlight that any work that we do would not be complete for the great team and the great people that I work with at our institution, and I just wanted to say thank you to everyone, including our team. Many thanks. Assalamu alaikum.
Walaikum Assalam, and thank you, Dr. Razak, for such an excellent presentation. I have a question. So how do you treat the GIST patients with exon 30 mutations?
So this is at the moment we're still using imatinib, but we know that these patients may not benefit, so you'll be quick to escalate. But the hope is, as drugs like Avapritinib comes in, or even Avapritinib, even though it failed in all comers, these are the patients that you want to start on these new agents, because their activity in exon 13 or exon 17 KIT mutations are quite astounding. And we have patients that have been on this drug for years when they have failed imatinib within a short period of time. So a highly active drug in this space.
Avapritinib, so the last TKI which you were discussing.
Yes, so both of them have got activity against 13 and 17, but I think at the moment, globally, I don't know how it extends to Pakistan, but here in Canada, we can get Avapritinib as a single patient access. We cannot for non-D842V mutation for Avapritinib because they don't have great data yet, but we know it's active in those space. So again, I think if you have a patient like that, that's failed imatinib, I think I would venture for you guys to explore whether or not you can get single patient use program to start in Pakistan.
That will be great. Another question, that the phase 1 and 2 trials with PD1 and PDL1 agents were negative initially, although they say that the expression of PD1 and PDL1 is increased in metastatic sarcomas. So what was the reason for that? And now we are seeing that the phase 3 trials are showing results, as you've already shown us.
Yeah, so the utility of PD testing, PD1, PDL1 testing is wrought with difficulties. Even if you look at other diseases, it's not consistent with who benefits from what. I don't think we have got a good sense that PDL1 expression actually matters in sarcoma. In fact, if you look at ASPS, for example, that's a good example. It's a highly cold tumor, so they don't have TILs. And the PDL1 expression is negative, it's 0 in essence. But yet you get profound changes when you apply that treatment. I don't think we have a reliable biomarker to know who benefits from immunotherapy versus not. But we know that there are some tumors that have got activity, classically liposarcoma, UPS, ASPS. We know some tumors are highly resistant. Meaning leiomyosarcoma is a good example. We're starting to make inroads, but for example, synovial sarcoma, giving checkpoint inhibitors is completely useless because it just doesn't work. So I guess until we dissect these as individual entities, we will have problems understanding where we go. So that basket type approach is going to be very, very important.
Yeah, you're right. So in SARC SARC 028, PDL1 expression wasn't tested, wasn't checked.
Well, I think they have biopsy samples. I think their correlatives is neither here nor there. I think there is data on PDL1 testing, but they don't correlate to benefit or resistance. But you must remember for SARC-028, when they initially presented, that's based on 40 patients and 10 to 11 patients per cohort. It's far too small to make any references to a biomarker difference.
Yeah, agreed. You're right. Thank you so much for an excellent presentation. And our
Thank you.
next speaker is Dr. Zishan Ahmed Alvi. He is a graduate of Army Medical College and a fellow of College of Physicians and Surgeons Pakistan and fellow of Royal College of Radiologists, United Kingdom. He is working as assistant professor and consultant radiation oncologist at Combined Military Hospital, Rawalpindi. Dr. Alvi has a special interest in breast, head and neck cancers, and sarcomas. And the title of the talk is Role of Radiotherapy for Soft Tissue Sarcoma. Thank you, Dr. Zishan, for joining us, and over to you now.
So, Bismillahirrahmanirrahim, thank you very much for introducing me. I have been given a really huge topic, the role of radiotherapy in soft tissue sarcomas. I have to cover it in 30 minutes. I'll try to be brief. There is a lot to be said, and this is where I work, Combined Military Hospital, Rawalpindi. So, soft tissue sarcomas, basically, it's a rare tumor. Sarcomas are 1% in adults and 15% in pediatric patients, and soft tissue sarcoma are even rarer. We don't have exact data because mostly just were not included in the initial data. They're so rare that on average, a general practitioner may see only one patient in entire career. And another issue with soft tissue sarcomas is they're heterogeneous. There are more than 50, rather more than 150 histological subtypes, as we recently learned. There are around 40% soft tissue sarcomas. They occur in extremities, and less than 10% they are in the head and neck region. But we do see retroperitoneal trunk and visceral soft tissue sarcomas. My talk would not be including Ewing sarcoma, extraskeletal Ewing sarcomas, or rhabdomyosarcomas. So, in the natural history, the soft tissue sarcomas, they tend to invade along muscle fibers and facial planes. Mostly they relapse distantly or locally. They don't metastasize to lymph nodes commonly, except there are a few exceptions like clear cell carcinomas, clear cell sarcomas, cutaneous angiosarcomas, rhabdomyosarcomas, epithelioid sarcomas. They're best managed by a multidisciplinary team meeting. Surgery still remains the main treatment of soft tissue sarcomas, but the role of radiologist, pathologist, medical oncologist, radiotherapist, physical therapist, and allied health professionals cannot be ignored. There is no doubt that experiencing in a multidisciplinary team by an experienced center is associated with better outcomes. And this data is available over almost more than 20 years. Those centers which are high volume centers, their results are better than those who rarely treat sarcomas. So it's best to have them treated in an MDT and in the centers where we have experience of treating soft tissue sarcomas. So I'll divide my talk in basically two subtypes. One is the soft tissue sarcomas of extremities and trunk, followed by rhabdomyosarcomas. As we have already know that extremity sarcomas, they are the most common one, around more than 40%. So I'll like to discuss them as low grade and high grade one. For low grade, generally usually is the sufficient treatment. If there's a wide sections with negative margins, local recurrence is less than 15%. And survival rates are typically more than 90%. Indications for radiotherapy in low-grade soft tissue sarcomas are if there are positive margins and that cannot be amenable to further surgery, or if there is recurrence, already one surgery has done, second surgery is done, and now we radiate them to prevent further recurrence, or if their location is such that they cannot be undergone by, they cannot be resected by salvage surgery. So there is a role of radiotherapy in low-grade soft tissue sarcomas only in these settings. Mostly, if wide local excision has been done with negative margins, we don't need radiotherapy. The situation is different for high-grade soft tissue sarcomas of extremity and trunks. We need surgery, and most of the cases also need for post-op radiotherapy. So limb sparing surgery and radiotherapy is basically standard of treatment, and this improves local recurrence and can prevent amputations and debilitating surgeries. So local recurrence with a combination of these two, surgery and radiotherapy, is less than 15%, but the survival is dependent upon grade as well as size of the tumor. So in the soft tissue sarcomas of extremities and trunk, from 1980s to now, we have so much data. The first trial in 1982 of National Cancer Institute shows that if we give radiotherapy along with surgery, amputation can be avoided. And there was equivalent overall survival, and the local recurrence rate was equivalent of 15%. Then we see that addition of radiotherapy along with limb sparing surgery in the form of external beam radiotherapy or brachytherapy gives equivalent overall survival, and there is improved local control with radiotherapy. So this is the data of NCI, in which addition of radiotherapy gives improved local control. We can see that percentage of patients with local control is reduced. So radiation gives a benefit at 10 years if we see that there is more than 90% recurrence-free survival, and if we don't give radiotherapy, it is around 70%. In the Memorial Sloan Kettering Center experience, they add brachytherapy after surgery, and here again the same results can be seen, that the local recurrence is reduced, and both of them are statistically significant. Now coming to radiotherapy planning, I would like to add this portion because most of the people who are not doing radiotherapy, they are not aware of what actually radiotherapy is doing and how we do it. We need to have patients scan in a reproducible, comfortable position, mostly spine. For tumors of extremities or for tumors of back, we may need a prone position. Then we need to immobilize patient because the treatment has to continue for 5 weeks, or in some cases more than 6 up to 7 weeks. So we need patient to be treated in the same position. So we immobilize them, and we use different methods to immobilize patient. There's an important aspect that we have to spare a strip of limb circumference that should receive less than 20 gray. Otherwise, edema that can be very troubling, and later side effects, they will be increased. And we try to keep our dose reduced to joints and bones, and we try to avoid hot spots in a subcutaneous tissue because that leads to radiation-induced fibrosis, which is too debilitating. This is just an example how we will be immobilizing a patient who upper limb patient we are treating by immobilizing his hand in a thermoplastic sheet. For foot, we can make a custom made, which is individualized to every patient, just to immobilize their leg and have a reproducible position daily. So there's a debate going on, and it's probably never-ending debate, whether pre-op radiotherapy is better or post-op radiotherapy is better. So I'll just be having a brief comparison whether pre-op or post-op radiotherapy, which is better. First, I will touching the pre-op radiotherapy. If we are giving radiotherapy before surgery, the radiotherapy volumes we use basically T1 MR-rated image, and then we expand GTV as per guidelines to create, generate a clinical target volume, and we also include T2 linear edema if feasible. They are, as I have said, they are rare tumors. We don't have much of the data or randomized controlled trials to guide us, and the guidelines are based mostly on retrospective studies. This is a study that takes 4 centimeter in the craniocaudal direction and 1.5 centimeter in the axial direction clinical target volume that is added to GTV in the pre-op settings. This was what we used to do traditionally. Then in 2015, there came a trial by Wang that reduced the volume of CTV volume, which is being irradiated, and they confirm it by adding daily imaging using IVKV, MV, or cone beam CT. In this RTOG trial, instead of giving 4 centimeter craniocaudally, they divide the volume based on the size of the tumor. If the tumor is more than 8 centimeter, they give 3 centimeter craniocaudally, and then 1.5 centimeter radially. And they also covered the edema on T2 weighted MRI. For tumors less than 8 centimeter, the CTV was reduced to 2 centimeter craniocaudally and 1 centimeter radially, and they also covered the edema in T2 weighted image. This was a trial that had 2 arms. One arm was abandoned, that was combining chemotherapy and radiotherapy, but the radiotherapy arm, they had 79 patients, and there was no control arm, and to compare them with the historical control arm of NCI, and the 2-year local control rate was 94%, and there was less local grade 2 local toxicities. There was 5.3% fibrosis, 3.5% joint stiffness, and 5.3% edema, which are layered side effects. So authors concluded that there was significant reduction of late toxicities and absence of marginal field recurrence. That is really important. That all the recurrences were not within the CTV. They weren't outside the CTV or at the margin of the CTV. So they suggested that volumes for preoperative radiotherapy can be reduced from 4 centimeter to 2 to 3 centimeters, depending upon size of the tumor. And this they concluded that this is a practice-changing trial. Now coming to post-op radiotherapy volumes, again, we don't have a very hard evidence base to make any recommendation about post-op radiotherapy volume. But when we are giving radiation post-operatively, we have to include tumor bed and any drain sites or whole of the scar. So at least 4 centimeter longitudinally, or sorry, in the first phase, we have to do at least 4 centimeter craniocaudally to the tumor bed, scar, and drain sites. And we give first dose of around 50 grays, and then in the we cone down the dose in the second phase to 2 centimeter longitudinally and 1.5 centimeter radially. There was a trial, Vortex trial, that has been recently published. That has then been published. It was in an abstract form that compared the reduction of that the phase 2 that uses 2 centimeter after giving 50 gray as a control arm, that the whole treatment is given to 2 centimeter volume increase craniocaudally. They're not able to recommend that this is a standard of care, and the published results aren't available yet. But we do know that toxicity with reducing volume remain the same. So coming to post-op radiotherapy doses, if we give radiotherapy pre-operatively, we give less dose. It is 50 gray. And if we give post-operatively, we have to give minimum 60 gray, but from positive margins or some high-risk cases, we may have to go 66 or beyond. So pre-operatively low dose, post-operatively high dose. Coming to post-operative doses and margins, if there's a positive margin, there are high chances of local recurrence. In that case, the dose has to be increased. So if dose is less than 64 gray, there were more chances of having local recurrence, and giving dose more than 64 gray is statistically significant. Our practice is to give at least 66 gray for a margin positive disease. For negative margin disease, we give 60 gray is acceptable dose. So again, comparing pre-op and post-op volumes for soft tissue sarcomas, we have lower doses and small radiated volume for pre-operative therapy. For post-operative therapy, we have to give a high dose and that to a large volume, because we have to include, there's no tumor and there is in the scar, there are drain sites. So we have to give radiate more volume to a higher dose. Coming to efficacy of pre-operative and post-operative radiotherapy. As far as efficacy is concerned, both of the arms, pre-operative or post-operatively, there are several non-randomized trials that have shown that local control rates are same. The Canadian randomized control trial and its 7 years update shows that the local recurrence rate, disease-free survival, and overall survival remains the same. So, what's the difference between the two? They are equal efficacy, but their toxicities are different. For pre-operatively, we have more acute complications. Acute wound complications are 35% versus 17% if radiotherapy is given post-operatively. For post-operative, the long-term side effects like edema, fibrosis, risk of fractures, decreased age of mobilities, they are more. The toxicities we encounter with pre-operative therapy are usually reversible, but the late toxicity we observe with post-operative therapy, they are usually irreversible. So again, they are equally efficacious, but there are different toxicities, and treatment approach should be individualized based on patient. There's a trend, overall trend in radiation oncologists or in the MDTs, that we prefer pre-operative therapy because we have to radiate lower dose, we have to deliver a lower dose and small volumes and less long-term irreversible toxicity. Now, just a brief discussion about how do we deliver radiotherapy? How should we deliver radiotherapy rather? So traditionally, there used to be 3D conformal radiotherapy, and for last 10 to 15 years, IMRT is in vogue and it's been more commonly used. So with IMRT, the goals are to improve local control rates that are achieved with 3D and to reduce the morbidity, especially late morbidities, edema, joint stiffness, fibrosis, fractures. So we have a lot of data. There have been no randomized trials comparing the two, but if we compare the data, we see that the 5-year local weakness rates remain almost similar over a decade with either 3D or with IMRT. So this is the experience of Memorial Sloan Kettering Center over almost 2 decades, and they see that the 5-year local weakness is less with IMRT as compared to 3D conformal radiotherapy, and it is statistically significant. So multivariate analysis of IMRT, they say that IMRT is an independent risk predictor of local weakness. And again, there is the patients reported to IMRT, they have unfavorable features, despite the fact IMRT proved to be more efficacious in preventing local recurrences. If we compare the toxicities, so here comes the main difference. So 3D or IMRT, as far as efficacy is concerned, we can say they are equal, but as far as toxicities are concerned, when we see the toxicities, we have so many series that reveal that toxicities with IMRT, they're quite less. For example, we have around 30% subcutaneous fibrosis that is reduced to less than 10%. Then 17% joint stiffness is again almost same or less. Then edema is also reduced. So use of IMRT may be the reason of reduced toxicity in the recent trials. And we also see the trend in the trials that old trials, they have more patients who are being treated with 3D, and all the new trials, they're mostly patients who are being treating on with IMRT. Local control rates with IMRT with 3D are at least similar, if not better, and the toxicity seems to be lower with IMRT. So there's a trend toward using IMRT, and I think IMRT is now standard of care. Coming to wound complications with pre-op and post-op radiotherapy, as I've already mentioned, acute wound complications, they are increased after if we are giving pre-operative radiotherapy. And with pre-operative, it's 35%, and with post-operative, it is 17%. But there are many predicted factors like size of the tumor, or there are more toxicities in the lower extremities as compared to upper extremity. Now again, in other studies, diabetes, tumor size, again the same, and distance of tumor from the skin. If it is less than 3 millimeter, the chances of having skin toxicity is more, or a vascularized flap is used or not. They also depend how much immediate wound complications we're going to have if we are giving preoperative radiotherapy. If we compare the late side effects, they are more prominent with post-operative radiotherapy, like fibrosis, edema, and joint stiffness. They are more with if the radiotherapy is given after surgery. So large field site is also associated with late side effects like fibrosis, edema, and joint stiffness. As we have already discussed, that if we are giving radiotherapy post-operatively, by default we have to have a larger field size, because we have to, there is no tumor, but we have to take hold of the scar, drain sites, and preoperatively where tumor was, tumor bed has to be radiated, and the margins have to be 4 to 5 centimeter caniformly in phase 1, which are coned down to 2 centimeter in phase 2. Bone fracture is also a late complication, and that is dependent upon how much dose we have given to the patient. So again, the late side effect of bone fracture would be more if more doses being given. In Memorial Sloan Kettering Center, they have 205 patients whom they give radiotherapy, and they found that the periosteal stripping, female gender, and use of chemotherapy increases the chance of having bone fractures. In the Canadian experience, if the volume, the bone receiving the volume is less, for example, the volume receiving 40 Gray is less than 64%, and the mean bone dose of less than 37 Gray is associated with less chances of bone fracture. I would just like to show you a case of soft tissue sarcoma of trunk. This is a young patient of 32 years old. He has an undifferentiated pleomorphic sarcoma of posterior chest wall, which is very close to vertebral body, rather invading the vertebral body. It is sparing the cord, but dura was involved. So the green one is the gross tumor volume. CTV is shown yellow in the axial direction, and the PTV is shown as red. We fuse the MRI with CT scan to have a better delineation of the tumor that help us reduce our volumes, because tumor is better visible on MRI, and the T2 edema is also taken into consideration. So I treated this patient with volumetric arc therapy, VMAT, and we can see this is a 95% isodose curve. This is we're giving preoperatively. Because of proximity to cord, I'm giving this patient dose of 45 gray instead of 50 gray, because I have to respect cord tolerance, otherwise this patient is going to have paraplegia. So in cases like this, where the tumor is too close to an organ at risk, where post-operative radiotherapy of 60 gray is next to impossible, the role of pre-operative radiotherapy comes into play. So regarding extremity and trunk tumors, in conclusion, we say that low grade, mostly they don't require radiotherapy unless there is positive margins, or their situation that further surgery, if required, would be debilitating. And in most of the high grades of tissue sarcomas, they require radiotherapy. Uh, Radiotherapy technique, again, immobilization and reproducibility are the factors. And preoperative therapy and post-op both are acceptable, have similar efficacy, but the post-op fibrosis, post-op late complications are more with post-operative therapy. IMRT is better. Again, acute wound complications are more with preoperative radiotherapy, but post-operatively late complications are there. Now coming to retroperitoneal sarcoma, again, they are a heterogeneous group. Since I'm running short of time, I will be a bit quick. Retroperitoneal sarcoma, they are again a heterogeneous group. They are composed which are around, you can say that they are different in the sense that they are very close to many organ at risk, like liver, kidney, small intestine. Usually the pattern of failure is local recurrence, which is 50 to 80%, and distant mets to liver and lungs are also there. They have a poor outcome as compared to extremity sarcomas, and 5-year survival is 30 to 60%. They are difficult to treat by surgeons as well as for radiation oncologists because of their large sizes and proximity to sensitive organs. Their favorable prognostic factors are if they are completely removed, they are low grade, or their primary presentation, recurrent tumors behave badly. Surgery is still the mainstay and only curative treatment. Role of radiotherapy and chemotherapy is not proven in retroperitoneal sarcoma, and there have been so much debate over it because they are rare tumors. We don't have good quality randomized controlled trials to assess the efficacy of things. So most of the data we have is retrospective, and the National Center for Disease database of disease, they say that preoperative or postoperative therapy improves survival benefit in patients. This was published in 2016. I'll be moving a bit quick. The limitations are there are retrospective trials. There is no details about resections. Data about local recurrence and histological types are also missing in most of the studies. And then there is a study meta-analysis published in March this year that take 10 out of 374 articles, and they say that the median overall survival and recurrence-free survival is improved with radiotherapy. So if we see that pre-operative and post-operative both improve median overall survival, and when we see the analysis, so median overall survival is increased by addition of either form of radiotherapy. 5-year overall survival again is better for both pre-operative or post-operative radiotherapy, and median recurrence-free survival is also improved. This meta-analysis was published in March this year. So if radiotherapy is given, the chances of having R0 resection are also improved as per this trial. But recently, in September this year, we have long-awaited results from STRASS trial. It is the first phase 3 randomized multi-center URTC study that studied efficacy of preoperative radiotherapy in retroperitoneal sarcoma followed by surgery alone. Radiotherapy delivery dose was 50.4 gray in 128 gray fraction, and mostly patients were treated with IMRT. Objective of surgery was to microscopically complete removal of the tumor, and primary endpoint was to assess recurrence-free survival, and safety analysis was also there. This is the trial profile. Almost both arms were balanced. The results were they showed that median overall survival was 43, median follow-up was 43.1, and 96% patients in surgery and 89% patient in radiotherapy and surgery arm had surgery. The abdominal recurrence-free survival was 4.5 months for radiotherapy and surgery versus 5 years, which is better for surgery. So radiotherapy doesn't seem to have a lot of role here in soft tissue sarcomas. The point I want to make here is, if we see there are so many meta-analyses based on that retrospective trials that say that there is benefit of surgery in achieving R0 resection, in reducing local recurrence, and even overall survival. But there is only one randomized controlled trial that says that there is no such benefit. If we look at this Kaplan-Meier curve, it is the data of all patients who underwent STRASS trial, and the blue one is showing the preoperative radiotherapy and surgery arm. Initially, it even looks inferior. At 5 years, there is no difference of, no difference in radiotherapy, no advantage of adding radiotherapy. I would be waiting for the long-term results at 10 years, because if we see that the graphs are separating at around 6 years. For patients of a liposarcoma subgroup, the situation was a bit different. These were the patients who appear to have benefit from addition of radiotherapy preoperatively. There were very high lymphopenia, anemia, hyperbilinemia with addition of radiotherapy, and one patient died of gastropleural fistula in radiotherapy and surgery arm. So toxicity was more, and when we analyze all patients together, there was no much benefit of radiotherapy, but liposarcoma subgroup was the one where we see some benefit. So authors conclude that radiotherapy cannot be routinely recommended for all retroperitoneal sarcoma patients, but the role of radiotherapy in liposarcoma should be further explored in prospective clinical trials. Well, just briefly touching, there's a new concept that when we are radiating patient with the advent of IMRT and VMET, we have options that we can increase dose to a specific area of the tumor, which is known as simultaneous integrated boost. So we can give high dose to areas which are having high risk of posterior margins, like which are very close to vessels, which are close to vertebra or some vital organs. So, but the dose painting and for high risk regions, it is not proven, it is under investigation, and ideally it should be done in a protocol by an experienced center. We need to understand that retroperitoneal sarcoma is a group of disease, and the way forward probably would be that we start treating them based on histology and molecular profiling. So I'll be there are so many, the two papers that were published in 2016 that tell us the different behavior of different liposarcomas. I will be discussing about leiomyosarcoma and liposarcoma, and again liposarcoma well differentiated behave differently, and dedifferentiated, and among dedifferentiated grade 2, 3 behave differently, and grade 1 behave differently. So the overall survival is different. Well-differentiated liposarcoma has the highest, around 85%, and dedifferentiated liposarcoma has around 30%. The local recurrence pattern is different based on histology. For leiomyosarcoma, it is 10%, and for dedifferentiated liposarcoma grade 1, 2, it is 48%. Distant recurrence is most with leiomyosarcoma and least with well-differentiated liposarcoma. So based on these studies, we know that they are different histologically, and they have to be treated differently. Going forward, we should tell our trials.
Yeah, your time is up, but we can give you a few more minutes to complete your slides.
Thank you very much. I'll be real quick. So going forward, we have to understand that there are a set of heterogeneous disease. So treatment should be individualized. And there's another trial which we are waiting that may confirm the findings of STRASS trial. It is their role of preoperative radiotherapy in retroperitoneal sarcoma. I'll skip this case. I just want to show that how we painted a dose in case of retroperitoneal sarcoma. We increase dose to the region where it is very close to vertebral body and aorta. So in conclusion, the only safe bet is to have an R naught resection. That is the main treatment. Surgery is the main treatment for retroperitoneal sarcoma. Radiotherapy is still investigational, and we are not sure whether it will work or not. But it is mostly given, and if we have to give radiotherapy preoperatively, is better. I would like to thank everybody. Thank you very much for your patience listening.
Thank you, Zishan. An excellent presentation. Although you have talked about this STRASS trial, still one of the attendees has asked you, what does the recently published STRASS trial say? Any conclusions in short? So if you can briefly reiterate what you've already said.
STRASS trial says that they cannot recommend radiotherapy, preoperative radiotherapy for retroperitoneal sarcoma in routine. But liposarcomas were the subgroup that showed a better response of radiotherapy. So what they concluded is that giving radiotherapy to every retroperitoneal sarcoma patient is not a wise idea.
Oh, okay,
But
great.
if we see the results of the trial, at 6 years we can see that the graphs are splitting. I would be interesting to look at the 10-year results of the same trial, what it comes out to be.
Okay, thank you so much. We'll take the questions at the end of the third talk. And now I would invite Dr. Masood Omar. He is orthopedic surgeon at Khan University Hospital, one of the leading hospitals in Pakistan, and it is located in Karachi. Dr. Masood Omar did his residency in orthopedics, followed by FCPS fellowship, and then he had the diploma on bone banking in 2007. Dr. Masood also did fellowship in limb lengthening from Russia and fellowship in arthroplasty in Singapore. He also did the orthopedic oncology fellowship in 2005 in Mayo Clinic and worked as a visiting clinician in Rizzoli Institute, Italy. Currently, Dr. Omar is associate professor and head of orthopedic department, Khan University Hospital. Dr. Masood has over 100 indexed publications. So today he will talk about the role of reconstructive surgery after skeletal and soft tissue sarcoma resection. Thank you very much, Dr. Masood. Over to you. Please unmute yourself. Walaikum Assalam.
Allahumma salli ala Sayyidina Maulana Muhammad wa alihi barik wa sallim alayhi. Can you see my screen?
Yes, we can.
All right.
Please go ahead.
Thank you for this kind introduction. And my talk will be quite different from my previous two speakers, based mostly on clinical cases and experience of handling sarcomas, especially in the perspective of reconstructing after skeletal or soft tissue defects. So as mentioned previously, recurrence is a major problem and it affects prognosis, and it is related to surgical margin. And the most important challenge for every sarcoma that I deal or we deal is to have a wide surgical margin. That's the most important predictor that would avoid recurrence. And Annie King from Florida, who expired a few years ago, described the resection margins as are shown here for soft tissue as well as for bone. And they basically include intralesional and then marginal and then wide resection margins and even radical margins. And as has already been alluded to, The importance of a multidisciplinary team, a tumor board, so as to say, is the most important treatment strategy that we acquired about 15 years ago. Now at AKU, we have regular orthopedic tumor board for adults as well as for pediatric patients separately. So the conflict is there that we remove the lesion wide enough to prevent recurrence. In doing so, we must keep the damage minimal, and we also stage the disease so as to know the behavior of the tumor and how far it has spread. Traditionally, limb salvage surgery has been associated with high failure rate, and as I said, where the primary goal is negative surgical margins, which can mean very large soft tissue defects, not amenable to primary wound closures. And if I can quote William Enneking, who's the father of limb salvage surgery, from his first meeting of ISOLs in 81, where 532 resections were reported with a local recurrence of 18% and surgical failure of reconstruction 15%. Then in the subsequent meeting after 10 years, um, the failure rate dropped. Hence the importance of discussing and sharing the cases. And also at the same time, improved methods of reconstruction following resection led to widespread acceptance of limb sparing surgery with improved functional outcome and survival rates comparable to amputation. Significant soft tissue defects may result from sarcoma excision, with exposure of tendons, bone, joints, vessel, and prostatic material, making substantial coverage very crucial. And sarcoma patients require reconstructive procedures that provide quality vascularized tissue with a brief healing period, thus enabling adjuvant therapy, be it radiotherapy or chemotherapy. So in the next 15 minutes or so, I'll be taking you through the following options in soft tissue reconstruction as well as bone reconstruction. So the possibility of primary tissue reconstruction allows the orthopedic oncologists like myself to proceed freely with complete tumor ablation without worrying about wound closure. Reconstructive surgeon uses the simplest procedure to cover a wound and then proceed to more complex procedures to achieve wound closure maximum functional benefit. The goal is obviously to reconstruct excised tissue, secure wound healing within reasonable time after filling the dead space, so that we can start adjuvant. Skin grafting has been the first step ladder in this reconstructive procedure, but now we go directly to flaps. So there can be local flaps or rotational flaps or free flaps. Free flaps meaning bringing a tissue with its blood supply from a distant place and anastomosing at the host defect area with the local blood vessels. Historically, it was thought that the vascular anastomosis for a flea flap needed to be outside the zone of radiation. However, recently it showed that preoperative radiation does not increase the risk of microvascular complication. Common flaps used, and I'll give you some examples. This was an 18-year-old male. The abdominal wall sarcoma referred to us from radiation oncology unit. He's had surgeries, as you can see, chemotherapy, and then radiotherapy also. We had no choice but to do a wide excision and to cover his defect. This is his abdomen. He's lying on his side. On your right is the buttock, and on your left is his thorax. Patient is lying with the sarcoma side up, more close-up view, previous surgery, then recurrence. That's how we excise, and that's the defect we created in the trunk wall. If you can see my cursor, these are the ribs which were exposed, and this is the abdominal musculature that was exposed, the resected specimen. But he developed another recurrence down the line, which had to be excised again. revision surgery. This is excision specimen. Again, the defect created, and again reconstruction by bringing a lateral thigh flap into the defect and covering and doing a local rotation flap also. So leiomyosarcoma of the right hand, a very elderly patient. Fungating mass. So we covered the defect, we lined up the resection margin, and this is what we did. And we took the metacarpals. This is the resection specimen. If you can see the X-ray, the metacarpals, the dorsal part of the metacarpals, as well as the extensor tendons, and reconstructed with a posterior introitious artery-based fasciocutaneous flap harvested from ipsilateral forearm to cover the defect, and the host defect was covered with split thickness skin graft. This was another 36-year-old male who had multiple surgeries across Multan and Lahore, and when he presented to us, he was like this. He had already had excision of his um, lower abdomen, perineal organs, and this was the recurrence now we were dealing with. Already had a suprapubic catheter. Another view, and this is what we have to do when we have to do a wide excision. Cannot spare anything that comes our way. This is patient in lithotomy position, and we had to open up both his thighs also to size the extent of the tumor, and then obviously he was reconstructed using these fasciocutaneous local flaps, the anterolateral thigh flap in this index case. Now, coming to bone reconstruction, because 5-year survival improves dramatically after section of malignant tumors, long-lasting durability is required in limb salvage procedures. Poor vascular bed and the negative effect chemotherapy and radiation is always there. And we have significant advances in endoprosthetic reconstruction, addressing unique challenges encountered in anatomically complex locations, as well as in patients who are young, skeletally immature. Workhorse is free vascularized fibular graft in which we harvest the fibula, as is shown here, especially in the lower picture, with its blood supply of the peroneal vessel. Right, shown here again. Fibula is an expandable bone God has gifted us, which can be used in multiple ways in a vascularized fashion and also as a non-vascularized modality. And this is an example, 12-year-old boy, resident of Lahore, osteosarcoma, biopsy done at Shaukat Khanum Hospital, the clinical picture, radiology, proximal humerus involved. This was our surgical plan. This is what I asked the residents to put up on the wall with their hand drawings and the plan. So this was the biopsy site, which is always included in the final excision. So final excision and defect, lower down, you can see the host bone, humerus. And this is the fibular graft harvested from his own leg. This is a glenoid, and which was tied in. This is a specimen X-ray tied in like this. This was the final reconstruction. This was non-vascularized, and this is 5 months post-op, and this is 3.5 year post-op, where it's very surprisingly to our experience and to our rare experience, we lost the whole bone, auto-digestion of the fibula despite no tumor recurrence on multiple imaging modalities. So we will handle that. That's a complication of non-vascularized fibulas where they don't have any blood supply, though they are actually as dead struts there. So probably the best solution would be to put a vascularized fibula. Now, Next modality we need to discuss for reconstruction is allograft, and reconstruction of large skeletal defect in children following resection of a bone tumor prosthesis presents a unique challenge. Goal is to restore long-term function and have a durable fixation. Bone allografts can be used for intercalary defect reconstruction or as osteochondral grafts also. We lack proper bone banks. The first one very recently established in Peshawar. Now we have very preliminary bone bank setup in Karachi, which is on ad hoc basis, not available to supply skeletally mature bone or structural bone. So we embarked on this innovative method of harvesting parental fibula from either the mother or the father of the child, use it as a fresh allograft. So they are both operated simultaneously. The parent is in another room and the boy patient in another room, and the fibula is brought to the operating room of the patient and fixed after resection of the tumor. So we published our experience in JPMA a few years back of this technique, which is quite successful, and especially the more younger the child is, the thinner are the bones, more difficult is it to create skeletal, to create a stable reconstruction, and that we thought would be very well done by a parental fibula, which is of reasonable strength. Now, the next modality we have used is autoclaving the bone. Now, these are all in the perspective of us working in the third world, where resources are limited, and we do not have options, as I said, of advanced bone banking facilities. And so we embarked on this project also to use tumor bone, clear it of its soft tissues, and autoclave them, which is a machine present within every operating room, and implant them back into the host defect. So problems remain of non-union and mostly of infection and fracture, because this is again dead bone and has to be supported. So combined use of autoclave bone and vascularized bone would seem to be the ideal graft for reconstruction because of the cumulative advantages arising from this approach. So the autoclave bone would provide immediate structural strength, and the biological properties of a vascularized bone would then be used to gain skeletal support futuristically. So we published our experience with pediatric bones, using autoclave tumor bone for pediatric patients quite successfully, and also almost 14 years back we published our autoclave bone experience in adults also. So this is a combined example. Again, a young boy from Lahore, 11-year-old child with right distal femur osteosarcoma, who underwent wide excision reconstruction with autoclave bone, parental fresh fibula, and ipsilateral non-vascularized support fibula. This was the initial X-ray, distal femur osteosarcoma reconstructed with a Phelos plate. Now you see the autoclave bone fits exactly the geometry of the excision because that's where it belongs. You just place it back, and then we placed in the middle, you can see the mother's fibula, and on the side is the ipsilateral fibula. You can see in the leg, it is harvested from the ipsilateral leg, and the whole fixation fixed with the plate and screws. This is now 10-year follow-up. Just met him on last weekend in Lahore and took his permission for these x-rays. So you see the autoclave bone has mostly withered off, and so has been the fibulae, two fibulae, but some structural support still exists. He drives, he's now 20. He drives, he runs, he walks, he can climb stairs, he squats, he says his prayers. So he is pretty much functional in his daily life chores. Now, moving on from autoclave bone, fresh allografts to another innovative technique that holds a lot of value for us in this part of the world is rotation plasty. When a salvage reconstruction procedure is not feasible and an above the knee amputation or a hip disarticulation would be required, this ensures better functional results by providing a longer residual limb with better fitting for an external prosthesis. All rotation plasties, however, require preservation of the blood supply to the distal residual stump. So I'll show you a couple of examples. This video is a small video. I'm sorry, it's not working. Just to show, I'll show you clinical example. This was an 8-year-old girl, osteosarcoma, and received new adjuvant. This is how it, the clinical picture. This is the knee joint, distal femur, osteosarcoma. X-ray, you see the posterior spread encasing the or abutting the neurovascular bundle, sciatic nerve posteriorly. She did not have any meds. So what we did was this. One is rotation plasty. These are rhomboid incisions that are used to excise the whole specimen, the distal femur as well as proximal tibia. This is the X-ray of the specimen. So extra-articular resection of the knee joint, fixing the tibia with the remaining femur. As you can see, this is tibia with the fibula fixed with the remaining femur, proximal femur with the plate. 5 years later, this is the bone that has healed. X-rays. This is the girl who has also grown up now. This is its limb. So the ipsilateral tibia leg has been brought up to be anastomosed or skeletally fixed with the femur. The remaining stump of the femur and has also been rotated 180 degrees to bring the foot backwards and heel forward. So now the ankle joint acts as the knee joint, with dorsiflexion of the ankle being knee flexion and plantar flexion of the ankle being knee extension with the prosthesis. You can see the foot moving in various directions. These are still pictures. And just to complement, so these are reserved this technique for tumors, especially big tumors who don't respond to chemo, not amenable to a limb salvage surgery where the vessels are encased. And usually you have to do a vascular anastomosis. See this case? We have resected the tumor, the distal femur and the proximal tibia. We only have the sciatic nerve connecting the two stumps now. The picture on your left, see the sciatic nerve dividing into posterior tibial and common peroneal branches. And we excise the vessel also. And next thing, picture on your right is the vascular anastomosis being done, and the tibia being brought up and rotated 180 degrees. This was the tumor specimen, X-rays, and this is the clinical picture. We nailed him this time, and this is another clinical picture with full movement of the ankle. And we make sure resection is done so as to bring the ankle exactly at the level of the opposite knee. We published our experience, one-ness rotation plasty, a few years ago. Now coming to the most popular reconstruction method, which is obviously the very, very stable and gives you the most early results in terms of rehabilitation, though that is prosthetic reconstruction, endoprosthesis. Various endoprostheses are shown in this picture, from proximal tibia to distal femur to the entire femur also. You see the picture fourth from the left, fourth from the right, sorry. Now, clinical examples of 20-year-old female osteosarcoma proximal tibia. We resect, create a defect, do a wide resection, spare the vessels, spare the nerve, put the implant and rotate a flap muscle over it. That's the implant, and that's the muscle rotated over it for coverage. And then we may have to do a skin graft. That is the implant with attachment provision in the proximal assembly for the tibial, for the patellar tendon. This is the biopsy scar, skin attached to the specimen, tumor specimen, post-op X-ray, follow-up X-ray. Another case, distal femur, another case, distal femur excised. And this patient also had a lesion in the proximal tibia, if you see. We excised that and autoclaved that and put it back, used a long stem in the tibia. You see that? And he's doing well, about 8 years follow-up, MSTS score of 87%. This is a gentleman from beyond Chakwal, the Sons Kesar Valley, a beautiful valley in Pakistan. He had angioembolization done, attempted in Islamabad, then ultimately came to ICU. This was his tumor, big pelvic ischial tumor spreading to anterior and posterior columns of the acetabulum, engaging the acetabulum. So this was the utilitarian incision, specimen, X-ray. This was the reconstruction done. We just left it as a girdle stone, a hanging hip method. We just hang the femoral head down from the remaining ilium, anastomose put the greater trochanter back and fix it with screws. So this follow-up after about 10 months. Another lady with chondrosarcoma of the pelvis, ischium, and mainly pubis. So metastatic studies were negative, utilitarian incision, excising the biopsy scar, the specimen, and this is the X-ray. So these are pelvic reconstruction examples where we did not do any reconstruction, we just loosely tied the femoral head to the remaining pelvis, in this case the acetabulum. This is 2 years follow-up. She is walking, although there is some proximal migration, but she is she's pain-free. I have a video separately. If I get the time, I'll show you. She's walking. She does all her household chores, and last month she told me that she is pregnant now, and we had a detailed discussion about it, about pros and cons of getting pregnant after such surgery, and this was after her waiting for 2 years and getting fully rehabilitated, ambulant without any upper limb now. This was an 8-year-old male, and scapula involved. Did a wide resection, again a girdle stone type of hanging shoulder, hanging upper limb, in which we hung the humeral head down from the clavicle. And this is the scapular excision specimen. The boy could do push-ups, and he demonstrated for us. This is still photographs, but I have the videos for it also, showing internal rotation, external rotation. And this was an adult this time, scapula GCT, in which we excised the whole scapula and then again did a hanging upper limb. We loosely tied the humeral head to the lateral end of clavicle with a Marceline tape. And this time he had some elongation there, some loosening of the tape, so we had to go in and refix. But this is 7-year follow-up of refixation, and he has stood there his course of time. This is still photograph. I have his video also. He can do his daily chores. If you get the time, we'll show you. Squamous cell carcinoma of the shoulder region. He did not opt for excision, went away. This was an initial lesion. That's how he came to us. This is his lying on the side. huge necrotic tumor. We were left with no option but to remove his entire upper limb down to the neck, brachial plexus and everything. This was the defect created, and we later put him on daily dressings for the infection to settle and everything. Did a flap later on. This tumor of the around the clavicle area,
Dr. Masood,
reconstruction done with the local.
yeah,
Yes,
you have
madam.
2 minutes. Yeah.
Bas, theek hai. So, another lady with chest wall sarcoma excised, big, it was growing, as you can see. We excised in oval incision, excised the whole mass. This is the ribs and the lung, you can see in the picture. Specimen, X-rays of the specimen, excised 4 ribs, reconstructed with a mesh, patient in the lateral position, reconstructed with multiple flaps and the mesh seen over the lungs. And this is the lady at after a follow-up of 1 year, and this is follow-up at 14 years. It's the same lady. Doing well, no recurrence. Very literate man, engineer in Gulf. He operated, he despite seeing it daily, he just ignored it. It was a MFH at that time, UPS, what we call now, after resection, a free vascularized fibula with the skin harvested. And this is his result, functional result at a follow-up of 16 years. Sometimes you are not able to do a limb salvage, we have to resort to amputation. Example of a 4-quarter amputation, very big tumor. This patient is somebody else, but just to complete the picture of post-op 4-quarter amputation patient. Upper limb resection, I'll just skip that in the interest of time. Just to show you combination of a Chinese flap, tumor around the elbow, resected specimen, reconstruction done, and a lateral medial plantar flap done for a melanoma of the heel, excised. Now, the possibility for soft tissue and bone reconstruction allows the oncologic surgeon to perform a complete tumor excision with adequate margins. Primary flap reconstruction helps to protect orthopedic mega implants and avoid deep infection. Maintain and also allows us to maintain maximum patient function without compromising on surgical oncology principles. The choice of reconstructive method applied is profoundly individualized, as I showed you, and tailor-made, and we have made some local innovations, as I showed you in my presentation. Therapeutic planning for sarcoma patients should be accomplished by a multidisciplinary team. That's what we follow for every patient. No patient is operated without being presented in a tumor board. The treatment pillars for obtaining good oncological results in treating extremity bone sarcoma, the precise diagnosis combined with excellent technique and adjuvant therapy, including radiotherapy. Proper resection followed by reconstruction is to be preferred over amputation nowadays, and numerous innovations are helping the surgeons obtain better margins and to provide solid reconstructions with acceptable patient morbidity. Thank you for your attention.
Thank you very much, Dr. Masood. It was very informative indeed. And there's a question from one of our plastic surgeon, and he wants to know what is your reconstructive strategy for tumors involving the vessels in thigh.
We excise them. A tumor
So,
encasing the vessels, you excise them, you bring in a plastic surgeon if required, but mostly here a vascular surgeon is required. Thighs hardly require plastic reconstruction because once you excise the tumor, you get a lot of room for closure. But if required, yes, we engage plastic, we engage vascular, everybody, whoever is required. Like the case I showed you for thoracic, it was done by thoracic surgeon, general surgeon, orthopedic surgeon, and a plastic surgeon. So 4 surgeons involved in a single patient. This is called tertiary care management. It has to be there before you embark on such difficult cases. Can't do them otherwise.
thank you so much. Another question, and what is your opinion about extracorporeal irradiation and reimplantation in osteosarcoma. Is there an established role for it as of yet?
Yes, there is. Obviously, people in Tata Memorial, Bombay are doing it, and I visited them. I saw the technique, but at that time we did not have any radiotherapy facilities in-house. But now we have a well-established radiotherapy department within our university, and it's just our success with autoclave bone that we have been persisting with that technique. The autoclave bone or radiotherapy bone or pasteurized bone. The third technique is pasteurization. So either of them can be used provided you have negative frozen sections at the end of your technique. And we are happy with autoclave bone. It's very cheap, so we are persisting with that.
Okay, thank you so much. So we'll move forwards with our case presentation, and I have a panel with us. I would like to introduce them first. First of all, Dr. Muhammad Abbas Khokhar is one of the leading oncologists, and he is working at the largest public sector institute, Mayo Hospital, Lahore. He is heading the Department of Medical Oncology and Radiotherapy, and under his guidance, he's supervising the students of FCPS Medical Oncology, MD Oncology, Diploma in Clinical Oncology, and he has many publications under his name. Most recently, he's been actively involved in research, and he is doing his PhD on induced pluripotent stem cells and engineering the genes according to particular disease. Thank you, Dr. Abbas, for being with us. We have Dr. Ilyas Rafi, one of the pillars of our sarcoma team, and he's been handling all our sarcoma patients single-handedly for years. He was joined by one of our another colleague, but then he left, and now most recently another orthopedic surgeon has joined, Shaukat Khanum. So thank you so much, Dr. Ilyas. He is a graduate from King Edward Medical College and did his FRCS from Royal College of Surgeons of Ireland. Dr. Ilyas also did his master's in orthopedic surgery from University of Dooney in UK, and he is one of our assets for the sarcoma team. Then is Dr. Kashif Siddiq. He is a consultant radiologist working with us. He did his fellowship from Royal College of Radiologists and then fellowship from College of Physicians and Surgeons of Pakistan. He has also done a fellowship in body imaging and fellowship in musculoskeletal radiology from Royal Liverpool University, UK. So he worked as a consultant radiologist in East Lancashire Hospital in UK as well. Last but not the least, the backbone of sarcoma team is Usman Hassan. He is his consultant histopathologist and head department of histopathology. He is the one who gives us the reports, and from there we take our patients. We plan all the treatment based on what Usman tells us. He did his fellowship in surgical pathology in 2013, and he did his FRC path as well. He was consultant histopathologist at Bristol Royal Infirmary Hospital, UK, and he is HOD here at Shaukat Khanum since 2019, and more than 65 publications for Usman Hassan. Thank you all. Dr. Razak, are you there?
Yes, I am.
So one of my colleagues, another orthopedic surgeon, he's asked you a question before going to the case presentation. Dr. Ahmed Shoaib asks, any role of immune therapy in preventing recurrence of synovial sarcoma? I think he's asking about adjuvant therapy or neoadjuvant.
So there is no data to suggest that adjuvant therapy works in synovial sarcoma. Whether it be chemotherapy or immunotherapy. So at the moment, the recommendations is not to provide adjuvant therapy in terms of chemotherapy for these patients.
Okay, thank you. Dr. Abbas, do you agree with this? Please switch on your mic. Unmute your mic.
Okay, I agree with this. There is currently no data available for this. So immunotherapy is still under trial, and there's no data currently that can be quoted for this question.
Thank you. So I will request all the panelists to please come on the video. We want to see you as well as we go through our today's case. Can you see my slide?
Not yet.
Do you see it now?
Not yet.
I'll ask the MIS team to please help me because I can see why is it not being shared.
While we are getting through the slides, if Dr. Omar is around, I would like to ask him a question. Masood Omar, if he is here.
Yes, sir.
Assalamu alaikum, Dr. Omar. It's always a pleasure listening to you, and it's always learning experience. And we can listen to you. I can listen to you for days and days, and I won't be bored. So my question is, what about liquid nitrogen recycling of the bone, like for the bone defects? We are doing it for the last couple of years now, and we have a number of cases lined up, and we will be publishing it. But I really like to know your opinion about your comments on it.
जी जी बिल्कुल. So from a personal perspective, zero experience, but from a academic perspective, I think very valid technique, well established by actually from Tsuchiya in Japan, Kanazawa, and from there he has spread this world all over the world actually of using liquid nitrogen. I guess very easily available locally also. I haven't explored it, but that's what colleagues in Karachi tell me. Civil Hospital Karachi is using it very regularly, very successfully also, and so is Indus Hospital now. So all for it, sir. Whatever is available, the bottom line is whatever is available and whatever I am comfortable with in terms of reconstruction, I will use. Since I have been personally engaged with autoclave bone, so my mental clock has been fixed there. But we have published our results. We have proven that it's a safe technique, it's a successful technique. Obviously, it has its limitations, as there are limitations with every technique.
That's very true. But I'm really impressed by that you have made a bone bank there in Karachi. And the other new thing I learned from you is the parents donating the bone to the child. Well, that's also something new we need to discuss further in our next meeting. We can, yeah.
Sure.
Yeah, thanks.
So we can go ahead with our case, maybe?
Yes, please.
Yes.
So this was a male, 47 years of age, and he was teacher from the city of Multan. He noticed a painless, slow growing mass in the left groin for last 6 months, and I'm talking about December 2011. He underwent resection at an outside facility and presented to us with histopathology report. And I would request Usman Hassan to please tell us what did the histopathology show.
Yeah. So this is one of the sections taken from the resection specimen. It was, I guess, it was back in 2011. So it was about 8 centimeter resection specimen. And our policy is to take 1 to 2 sections from every slice of the specimen, not to miss, especially the high grade areas. So since most of us are non-pathologists, previous slide, please. Previous slide.
Yeah.
So yeah, so the dark circles you can see at the left side of the image are actually the skeletal muscles, and you can see the whole of the tumor is actually infiltrating into the skeletal muscle. So this is a lowest power view in which we get to know that this is the tumor, and this is a malignant tumor we are dealing with. Next, please. Yeah, so in the lower portion, you can see some fat cells, and this tumor is also infiltrating into the surrounding fat as well. So this is clearly an infiltrating tumor on low power view. Then we go to the high power. Next, please. Yeah. So you can see that there are cells which are actually very irregular, spindle to irregular cells. And usually the low grade or intermediate grade tumors that resemble the structures they are arising from. And we get an idea which kind of sarcoma we are dealing with. But unfortunately, in very high grade tumors, all high grade tumors can look alike. So we have to actually take the help of immunohistochemical stains. So in this picture, you can, yeah. So in this picture, I have actually captured a lot of mitotic figures. You can see some blasting effect, bursting out effect of few cells. Sorry, I don't have the pointer to show you, but this is one of the most important. Yeah, very good, Dr. Mickelson. You know the pathology. So yeah, so this is one of the most important factor or component we actually calculate in grading of the tumor. We grade all the sarcomas according to the FNC-LCC grading system. Mitotic count is one of the few. This is one high power field which is showing 4 or 5 mitosis, so it's clearly a high grade sarcoma. Next. And this I have captured one of the margins. So we ink all of the margins with different inks. So if from the in-house surgeries, they are very well oriented. And also from most of the outside hospitals, they are now orienting the specimen well. So we ink the specimens, our specimens with different inks, and you can see that the tumor is almost reaching one of this blue intersection margin. Yes, please. Yeah, so I was telling you in high-grade tumors, we have to actually take the help of immunohistochemical stains. And as a first step, we apply very basic immunostains like for muscle, SMA, Desmin, for vascular origin, CD34, then for epithelial origin, CK, not to miss sarcomatoid carcinomas. Then for neural origin, melanocytic origin, we do SOX and S100. So I have put only the image which was positive. This is actually smooth muscle actin, and this is diffusely positive. The brown stain, you can see, we all see this in positive immunostain. So this tumor is diffusely expressing for smooth muscle actin, whereas it was negative for all other markers. So we labeled it as high-grade leiomyosarcoma FNCLCC grade 3, with a tumor size of 8 centimeter, and it was very close to the margin. I guess it was involving some margins.
Yeah, it was margin positive.
Yeah.
So, Kashif.
Yeah, so all our sarcoma patients we do have at Shaukat, we do staging workup in the form of MRI for local staging of the tumor. We do CT chest to look for the pulmonary metastases and the bone scan to look for the bony metastases. This is MR from 2011. It's a scanner of low strength. At that time, you can see the resolution is not bad, very crisp. This patient had a mass in the left groin, but what we see on this MR, the left psoas is bigger. Its T1 is ISO to high signal intensity with high signal on the fat saturated sequence just on the left side of your screen. And on the top, on the right side, you can see a sagittal image with the soft tissue high signal intensity mass involving the left psoas muscle. So there wasn't any residual tumor in the left groin, but he had this soft tissue mass within the left psoas muscle. It's an intramuscular mass. The differential possibilities of masses in this location includes either the infection, but on the post-contrast, it wasn't showing the peripheral enhancement. It's more sort of a solid mass. So it has to be a soft tissue lesion. So we raise the possibility that it's another lesion within the left psoas muscle and ask for a biopsy of this mass. There wasn't any retroperitoneal lymphadenopathy. There wasn't extension to the spinal canal. There was no erosions of the adjacent spine. So it's a purely intramuscular soft tissue mass, one of the sarcomas on the imaging.
So thank you, Sman and Kashif. On
the
CT
left,
chest.
Can I ask question?
Yeah, sure.
The left paraspinal muscle is okay, sir?
Kashif.
Yeah, left paraspinal muscle is they're okay. So on the center one is the T1 sequence. That's the without fat saturation. On the left side is the fat saturated sequence. The paraspinal muscles be quite symmetric. It's just the incomplete fat saturation you see on the top on the most left hand sequence that's making it more brighter. It's actually the incomplete fat suppression. That's why the paraspinal muscles appear a bit more hyperintense on this particular image. But actually, there's no underlying mass.
Thank you.
So the staging workup was negative for any distant metastasis. We took our case to the multidisciplinary team, and I would ask my panel what should be done now. So radiotherapy, neoadjuvant radiotherapy, or chemoradiotherapy, or surgical excision. Dr. Razak, are you there?
I'm there, but unfortunately my camera doesn't seem to be working. So
okay, but you can see my slides.
I could, yes.
Okay, great.
So the biopsy from the parasoas area was consistent with the leiomyosarcoma as well?
Yeah, it
Yes,
was
I agree.
leiomyosarcoma, 8 centimeters, margin positive, and there's something on the source as well.
Yeah. So, but the thing on the psoas is LMS as well?
I mean, that was not biopsied, but the radiologist thought so.
Okay. So I guess, we are probably talking about one entity of disease.
Mhm.
The issue here is that it's probably an unusual metastasis. Soft tissue metastasis from LMS is not that uncommon, but we don't frequently see it this way. If you look at this, this is an area of two discrete areas of disease. Although you could call this oligometastasis, if it's really metastasis, the problem is the disease is systemic. So at our institution, we would actually give chemotherapy, let the disease biology declare itself. In the presence of further progression, then you know for sure that you couldn't do much. But if you can stabilize the disease, then it opens to strategies for local treatment, be it radiotherapy alone or radiotherapy and surgery.
Okay, and thank you so much for your input. Abbas, what do you think?
Well, in this case, we know that in every case, surgical excision, whenever possible, should be done, but it doesn't seem to be accessible. That is why the other options that include as radiation therapy and chemotherapy should be considered. And I would like to go with the radiation therapy first, and then we will see how the tumor behaves and how the response comes out.
Okay, thank you. Zishan?
So leiomyosarcoma,
Yeah.
I'll be giving both chemotherapy and radiotherapy in
Oh,
preoperative setting, followed by resection.
great, thank you. So we are talking about, I mean, 10 years back, December 2011, at that time, neoadjuvant chemoradiotherapy was not that established, not even now. So the MDT recommended that neoadjuvant radiotherapy should be done and then resection be done. So he was planned for radiotherapy 50 grays in 25 fractions. Which completed in early May 2012, and immediately post radiotherapy, as we now know that he had systemic disease, there was new left shoulder subcutaneous nodule. On examination, it was 3 to 4 centimeter firm mobile nodule, no axillary lymph nodes. We got FNA, which was positive, and clinically no obvious mets. This was the PET scan. Kashif, can you please?
Yeah, for these patients with oligometastatic disease with developing a new nodule elsewhere, intramuscular, so PET is a modality. Here we can see that there is on the CT component, we can see a slightly hyperdense enhancing lesion within the intramuscular compartment of the left shoulder joint that is within the deltoid muscle, and it's quite metabolically active. So this looks like a metastatic disease. There wasn't any lung mets, there wasn't any retroperitoneal or paraortic lymph nodes. So on this PET CT scan, you can see another focus of disease within the left gluteus muscle. So again, the two lesions look similar. They look like metastases within the intramuscular compartment on the left side. One is the left deltoid muscle that was biopsy proven. Another lesion with similar morphological appearances in the left gluteus maximus muscle. So there are two metastases within the muscles, no visceral metastases yet.
Great, thank you. So, Dr. Masood, what is your opinion now? He has metastatic disease with two, obviously, I mean, they can be resected, but what do you think? What should be done?
Now I think most likely we have lost the boat.
Yeah.
But I think in going back to 2011, I have seen cases with psoas muscle sarcoma presenting as groin mass. And that is like, I won't call them mets, but that is the continuation of the disease into the groin. Psoas muscle crosses the groin to attach to the lesser trochanter. And obviously it requires requires careful planning. As you go high up to the origin of source, you have big vessels very near, close to it. You have to dissect the ureter out, and you have to sacrifice the femoral nerve, which is lying on the surface of the source. So, but you're coming back to your question, I don't think anything can be done now surgically.
So, yeah, thank you so much. So this is what our board thought, and keeping in view the primary progressive nature of the disease, we gave him 6 cycles of chemotherapy, ifosfamide doxorubicin till September 2012, and the post-therapy PET scan showed reduction in size and complete metabolic resolution of the 2 masses, and then he was kept on surveillance and very aggressive surveillance. So we followed him up with 3 monthly chest x-rays, 6 monthly CT thorax, and PET scan as and when required. In February 2015, so 3 years down the lane, he reported an increase in the size of the deltoid lesion. Kashif, can you please take us through this, Emma?
So these are 2 sequences. One is the on your left side is a coronal, and on the right is the axial T2-weighted sequences. Here we can see that there is an intramuscular mass within the lateral middle belly of the deltoid muscle with the exophytic bulging component going into the subcutaneous tissues. It's at the same site where we saw a metabolically active tumor on the PET scan. So we labeled it as a progressive disease, progressive metastatic focus within the left deltoid muscle. You see there is no axillary lymphadenopathy. It's away from the bones. It's not involving adjacent neurovascular structures. So it's a progressive metastatic disease in only the left deltoid muscle.
So this is the PET scan, yeah?
Yeah, so same patient, we had a PET scan. You can see on the right side, the left psoas muscle has developed peripheral rim calcification with center necrotic areas. And on the top right, it's not showing metabolic activity. And on the left lower, you see the intramuscular metabolically active focus corresponding to MR within the left deltoid muscle. Meanwhile, he has also developed a small borderline right paratracheal lymph node as well. So the left intramuscular lesion is increasing with a borderline right paratracheal lymph node. The primary site of tumor within the left source is metabolically inactive at this stage.
Thank you so much. We took this to the MDT again, and now we know that he had a primary progressive disease initially, but with a good 2.5, 3 years disease-free survival. Razak, what would you do now?
So I guess, the biology of the disease is quite favorable after chemotherapy, but this seems to be very limited progression. I guess there is no right answer. The question of that lymph node, is, I think needs to be followed up a bit more closely, because these tumors don't readily go to lymph nodes in such a manner. So, at our facility, we have the ability to give SBRT. So probably these people, because they have oligomets, only 2 sites, we probably will give SBRT and then observe. But I wouldn't be opposed to the idea of systemic therapy. Again, the concept was to see whether the biology of the disease will declare itself.
Okay, thank you. Dr. Ilyas, what is your thought on this? Yeah.
Well, if looking at the lesion in the deltoid muscle, I think it's quite resectable, and it should be taken out. And like we discuss most of the time in our MDTs, that the surgical resection is useful in taking out the muscle bulk, most of it or all of it with negative margins, and the radiation has a role in clearing the remnants or the leftovers or the microscopic leftovers. XRT is quite effective. But to take out a big bulk of tumor surgically, I think should be tried wherever it is possible. And in this case, from the deltoid muscle, I think it was quite possible, and that was done at that stage, I think.
Thank you so much. Razak, I think we didn't have the SBRT facility in 2015. And Abbas, what will you do?
Again, we have already used the most effective chemotherapy regimen, and due to the limitation of giving more chemotherapy in terms of anthracyclines, we have the second line and third line chemotherapies or other agents that can be used. They are not probably that effective. So probably I would like to go with the surgical resection whenever possible, and my choice will be surgical resection in this case.
Dr. Masood, do you agree with us with the surgery resection?
Of the Mets or the primary lesion or both?
Or of this lesion which is lighting up, the deltoid?
Well, I don't think it would affect the prognosis. We can do it for cosmetic reasons.
Okay, thank you. So the MDT.
May I just comment one thing?
Yeah, sure.
I guess it's very interesting because each institution will use the tools that are available to them. So exactly. I think we have to recognize the fact that, when you have the hammer, everything looks like a nail somewhat. and there is no correct answer really. So I don't want the audience to think that there is a specific way you should dissect. From our perspective here in Toronto, declaring the biology of the disease is fairly important because because surgery to us, maybe it is different in Pakistan, surgery to us is one of the most resource intensive procedure, option. So we usually only do it when it's available. But in the absence of, radiotherapy that can be delivered effectively in a timely fashion, for example, perhaps then surgery becomes appropriate, which also highlights the value of tumor boards. Disease like sarcoma should never be treated without tumor boards and should always be done in high throughput centers. And I hope colleagues in Pakistan, whenever they see this, if they don't belong to a center that treats sarcoma, they should refer these patients accordingly and not proceed with surgery when they don't have the normality of treating these patients.
So you're very right, Razak, because we are from a resource constrained area. We do not have the facility or luxury of so many things down the lane. With given ifosdoxo, and the second thing is gemcitabine and docetaxel, whether you give it a combination or a single agent, and that is it. Not all my patients can afford even pazopanib. So the surgeons are the only hope that they can take out the disease, and if there's any requirement, we can treat it with radiotherapy. So,
but I hope the patients get treated with the consensus of a tumor board. So, all the major hospitals, they should be referred accordingly. So that, people don't come with a incompletely excised tumor, and then it becomes even more complicated for the people who treat this disease.
Oh, yeah, you're right. And we are one of the centers, apart from Khan University Hospital, where sarcomas are being treated, and we do a multidisciplinary board for every patient who presents, and then for recurrences if it is required. So this case was also discussed, and surgical resection was recommended. So the patient had a metastatic leiomyosarcoma, high grade, 3 centimeter in size, and all the resection margins were free of tumor. And it was 0.1 centimeter from the nearest posterior resection margin, for which palliative radiation, 400 grays and 5 fractions was given till in May 2015. And after that, he was kept on surveillance again. So a year later, 1.5 years, he noticed a swelling along the right shoulder, and we got an MR of the upper limb. It showed progressive nodular lesion along the anteromedial aspect, which was 1.9 into 1.7 centimeters. There was no other disease on the restaging scans. Now, what are the treatment options? Surgery, radiation, or systemic therapy?
Are you asking?
So we know that you will tell us about the systemic therapy, Razak.
Yeah, the reason why I'm harping about this is that as we go along, the disease is telling us that, you know, it's coming back with, you know, decreased disease-free interval.
Yeah.
So, you know, you can keep removing things, but I think you don't, you know, the bottom line is that you got the biology of the disease declaring itself. And I think, you know, again, you know, you have to discuss this in the tumor board, you have to discuss this with the patient. But the bottom line is, I think systemic treatment is where we should go. Now, the one difference here is that he had a remarkable response to doxorubicin-based chemotherapy. So if it was me today here in Toronto, I would actually give him Calyx.
Okay. Right, right. Interesting. And then again, our hands are tied. We do not have many agents. That is why we look to the local therapies and local options. And I totally take your point that when it is pronouncing again and again, systemic therapy should be contemplated. Abbas, what do you think?
Yes, at this time, probably we have only two options. One is systemic therapy, maybe pazopanib, and the second is that we can observe this patient. If the patient is not symptomatic, then we can, the lesion is small, then probably we can learn and we can follow the patient and offer the systemic therapy whenever there are symptoms.
Yeah. So we discussed it in the tumor board and we discussed it with the patient as well. He was not able to afford pazopanib and he had some hesitation towards chemotherapy, but the surgeon was kind enough and the lesion was excised again. So the pathology showed leiomyosarcoma 2.5 centimeters, all margins except one were negative, and post-op radiotherapy was given till December 2016. So again, he remained on close surveillance, and 3 years down the lane, new right lower neck nodule, but that was the FNA was negative for malignancy. However, we requested a PET scan on him. So Kashif?
Yeah, so this was a PET from 2018. There wasn't any site of disease that was metabolically active, except for a small focus of increased metabolic activity within the left serratus anterior muscle. So that's not clearly showing up on this limited images, but there was a subtle altered density within the left superior intramuscular compartment of the left serratus anterior muscle. It was metabolically active as well.
So now, Dr. Masood, what will you do? Dr. Masood Umar, are you there?
It's probably
Dr. Ilyas? Yeah.
Sorry,
Ilyas?
sorry, I missed the talk.
Oh, right. You didn't see the scan, so I'll go ahead. The lesion over the paraspinal muscles on the left is quite inviting for a surgeon. Especially in the past, we have seen that taking out the lesions helped him, and he has survived so far. It was actually a team effort with the oncologist and the radiologist and the radiotherapist and pathologists, everybody putting in. So I think when a lesion is so easily resectable, it should be taken out, especially in this case. Now we have a history for the last 5 years. So I would go for a wide local excision with the aim of negative margins on this case.
Thank you so much. So we have a very enthusiastic surgeon who helps us a lot. And this time again, in view of the slow pace and low disease burden, resection was recommended and it was successfully resected. It was 2 centimeters in size and 10 millimeter away from the nearest resection margin. So he was, what should be the next line of action? Dr. Zishan, radiotherapy, chemotherapy, surveillance, what will you recommend?
I'll go for surveillance.
Right, thank you. And Abbas?
Yes, I will also go for surveillance.
Razak, do you agree with us? Now that it's been taken out and it's negative margins?
It's not unreasonable, yes.
Okay, great. Thank you. So this is what we did. And this was in 2018. And in 2019, 1 year later, he presented with symptoms for which a CT scan was done. Kashif?
Yeah, so unfortunately, this time he has developed a metastatic nodule within the right lung. It's a solitary nodule, 1.1 centimeter, and it's metabolically active. This is consistent with the pulmonary metastatic deposit.
So again, we took him to the MDT and surgical excision was recommended. And thanks to the surgical and to the cardiothoracic surgeon who did VATS and wedge excision, and the histopathology was again the same, leiomyosarcoma, 10 millimeters, and tumor was 10 millimeter, I think, from the surgical ink resection margin. So Usman?
You want me to? Yeah, actually,
yeah, these are the alveoli.
Yeah, these are the alveoli on the left front corner and right side spittle cell lesion again. And it was again positive for SMA. Just to highlight a few things, because within the hospital, we get the complete history of the previous tumors, how many times it was resected, what was given, what was not given. One of the problems we face with the specimens coming from outside the hospital. So it is just to highlight that we need to know what kind of chemotherapy was given before, or just want to know that chemo was given or radiotherapy was given, because these high-grade tumors, they tend to lose their antigenicity towards our immunohistochemical markers. Even lymphomas, they tend to lose CD20, the sarcomas, they tend to lose SMA, desmin, and everything. So this was not a problem for us, but just to highlight for the cases which come to us from the outside, that history is very important for us. Thank you.
Yeah, thank you so much. And one of the participants is asking a question. I will ask Usman, is FNA adequate to exclude a soft tissue sarcoma?
Yeah, very good question. So in the past, we did not used to make cell blocks, right? So the cell block was not very common around the world, but thankfully now whenever we aspirate any tumor, we make a cell block, and that cell block is actually treated like the biopsy. And when we get the adequate material in the cell block, we can do all the immunostains and we can tell you what kind of tumor is this. So in most of the cases, yes. But again, in radiotherapy treated patients, chemotherapy treated patients, due to lots of fibrosis and lots of tissue reactions, sometimes the FNA is not that adequate. So negative FNA does not mean that a tumor is not there. Again, MDT discussion as is being highlighted again and again, PET scan and this, we have to rule out malignancy, still malignancy. But FNA with cell block is very, very important.
Okay, great. Thank you. So sorry, this is the immunostain which you were talking about.
Positive, yeah.
So treatment options. Razak, sorry, we are not listening to you. So what is the treatment option now? Surveillance or systemic therapy? Abbas, Zishan?
Yeah, according to the history, I think that you will go for the surgery again.
So it's been treated, it's been resected and negative margins in the lung. Now, what do you want us to do?
Yes, I would like to go for the surveillance one.
Zishan?
I like to go for surveillance as well.
Okay, but Razak is telling us to do something which we are not listening to him.
No. At this point, don't have really measurable disease, right?
Yeah.
I do not give chemo when there's no measurable disease. But the point is, I think we have lost the opportunity to know what it does on chemo. But again, I don't think it's wrong, because you got a good example here when the patient have done well.
Yeah, and you see that this patient is with us since 2011, and now it is 2020. So now there's a big problem. He noticed a thigh lesion, and it was clinically palpable, and the MRIs. Kashif?
Yeah, on this MR that was done on a follow-up, we see a huge mass within the left anterior thigh, extending towards the groin. It's within the intrafacial compartment, deep to the subcutaneous tissues, measuring around 5 to 6 centimeters in size. It's inseparable from the underlying muscles. Another focus of disease is seen within the right gluteus maximus muscle. So on this MR, we see two new sites of tumor, one within the left anterior thigh, away from the neurovascular bundle with its epicenter within the subcutaneous tissues, another within the right gluteus maximum muscle. And this is the follow-up PET scan that was done recently. Here we see that the left anterior thigh mass is quite big. It's metabolically active. The right gluteal mass is also metabolically active. So, and there is another focus of disease within the right psoas muscle, which was initially silent. So there are three sites of metabolically active tumor in this patient. No visceral mat seen.
Thank you so much. So this time we discussed it with the patient, but he was not agreeing for chemotherapy because he had some complications in the first line chemotherapy, which not first line, which was given in 2012, and he had some limitations as well. We discussed everything in our MDT, and Dr. Ilyas.
Yes. This time again, we thought that they are resectable, except for the one which is there in the sauce. So it was a combined decision in the MDT that the one in the sauce, which is quite hidden and not very resectable, easily resectable, should be done with the XRT, and the rest of the three, there was one in the right upper limb, if I remember correctly. So the other three, we will resect them surgically. So the resection was done. The one in the right upper limb came out, negative margins. On the right gluteal region, negative margin. And then we placed him on his back and went through his groin. This was a huge mass, and I think it had grown since the MRI was done, and we had a decision made in the MDT, and he was placed in those few days or maybe a week or so. It got even bigger. And when it was taken out as a whole as you could, but there was a limitation from the proximity of the vessels and nerves, the femoral artery and vein. They were very close to it. So it was lifted off from it, from surrounding tissues. But as a whole, actually, it was or debulked. It was a whole of it was taken out. Stand for histology. That's it.
So I totally agree. It was a combined decision to take out the three lesions and to do the stereotactic for the paraspinal lesion. Yeah, psoas lesion. But Razak, you see that the biggest is 7.5 and it involves because of the restrictions. How will you treat now? What will you offer him? Because we know he is not a candidate for the stereotactic to the psoas area. He has positive margins, especially to the groin area. What will you offer him?
So the patient has said no to chemo, right? So that's not an option. So what you're left with surgery, with radiotherapy, that area was not treated before because the radiotherapy that he received was only to the most superficial tumors as well as the paraspinal. So I don't know what Zishan will say, how much he can deliver safely to the area, but in our institution, this patient will get radiotherapy.
So if it is another patient with similar situation and he has no problem with chemotherapy, what will you do then?
So I would actually not go for surgery. I'll give, because you cannot remove that disease. So
yeah, exactly.
Doing surgery to the rest of the tumors will be academic. So again, I'll sound like a broken record here. I will give chemo, see what the disease biology is, and if they are good, it may open to more localized treatment option. So we are a strong believer of trying to get the disease to declare itself one way or another. Mm-hmm. The problem is once you remove the tumors, you don't know what you're treating.
Yeah. So there was a meta-analysis. There was a meta-analysis that doublet chemo and in the metastatic setting has no superiority. So what would you offer to such a patient?
Yeah, so in this case, I would actually recycle so this is a bit different, right? So the question is, can you downsize the tumor to open up opportunities? Because this guy has got oligomets, right? And he's
Yeah.
done very well. He's got favorable disease biology. He had responded to chemo. So I would actually look at options of how I can give combination chemotherapy to him to increase response rates. I wouldn't necessarily offer him gemcitabine, but I probably would give him Calyx ifosfamide. But I don't know whether you have access to Calyx or not.
No, we don't have it in Pakistan.
Yeah, so unfortunately then in the absence of that, the next best treatment is ifosfamide. But ifosfamide in leiomyosarcoma is unfortunately a very quasi choice. So probably he will go the gemcitabine route.
Okay, thank you so much. Abbas, what do you think?
Yeah, I would say that this case is a success story, and the major role is due to your very enthusiastic and expert surgeons. We in most of the centers, this surgery, the facility of this surgery is not available, and we usually succumb to systemic therapy very early on. Because the surgeons are not that capable in most of the places in public sector hospitals. But I would like to go for the surgery whenever there is a chance and that the disease is resectable, because the systemic therapy, most of them, they are palliative and they are very toxic as well. They are difficult to tolerate for the patient. So whenever possible, surgery should be the choice. And after that, if the surgery is not a choice, then probably the systemic therapy should be considered.
Yeah, thank you so much. And I agree to you, but then this is a patient, we'll talk to him again. And if he agrees, then I think chemotherapy now is the requirement of the hour. Thank you so much for this case discussion. And if you have any questions from our experts, I mean, we are all here. Abbas, want to ask some question? So I have few questions from Razak and Zishan as well. Razak, what is the role of chemotherapy, whether neoadjuvant or adjuvant in retroperitoneal sarcomas? What is your view on that?
So we do not advocate neoadjuvant chemotherapy for readily resectable tumors, but this is subject to the upcoming STRASS 2 study, where patients with liposarcomas and leiomyosarcomas are given chemotherapy only for 3 cycles pre-op. In the borderline setting, we have good institutional data to say that we employ tri-modality therapy to try and downsize the tumor. And we have got success rates with regards to that. Coming to Dr. Koka's point, I think if the approach in Shaukat Khanum is to do surgery upfront when you have got metastatic disease whenever possible, there is an excellent opportunity for your fellows or your residents to look to all the case records of the patients, because the one thing when you do case discussions, you have selective bias. And in this case, they are not usually the norm. This case is extraordinary in terms of biology and so forth. But I think what would be cool to see is that whether or not the approach of going for surgery whenever you can in the metastatic setting actually produces great outcome for the majority of the patients. So I think if you have your fellows and your residents there, that is a great project to undertake, and it will give you your local data to inform what you do.
Thank you. So another question from one of our participants, both to Dr. Razak and Abbas. Is dacarbazine another option for metastatic leiomyosarcoma?
Yes, it is. Dacarbazine and ifosfamide, gemcitabine, docetaxel, and these are all the agents that can be used. They are all they are used in palliative setting. They have a sort of response rates, but that is actually none of them has a very long progression-free survival, medium progression-free survival data. So that is why we can use any of these drugs according to our circumstances, according to the patient's conditions, priority, and in metastatic diseases we have actually limited options. So dacarbazine, yes, it can be used as well.
Razak, you agree with this?
Very much so.
Okay, thank you. So I have a question for Dr. Zishan. That you talked about that IMRT has an edge over the 3D conventional radiotherapy. What about the VMAT? Is it superior to 3D or the results are equivalent? What do you think?
Basically, VMAT is a modified form of IMRT. The difference is that when we say IMRT, by default, we mean it's a fixed field IMRT. In VMAP, basically it's an arc therapy. The gantry is moving, the dose rate is changing, and the field shape by collimators is changing. So VMAT is basically a modified form of IMRT. What's the advantage is that we can have a very good dose conformity. We can conform dose to the target volumes, and dose to organ at rest can be would be very low as compared to IMRT. The disadvantage is that the low dose bath will be too high for with VMAT as compared to IMRT. So whatever is true for IMRT is true for VMAT, and beyond doubt, VMAT and IMRT are superior than 3D.
Okay, great.
So
One last question.
the current consensus is give me a minute, please. The current consensus is that VMAT is superior to IMRT in most of the scenarios.
Okay, thank you so much. One last question. So, is there any role of stereotactic radiotherapy in soft tissue sarcomas? Because we usually see it in liver and brain and other areas.
Yes, for oligometastatic disease, if they are not resectable, stereotactic have a role. We don't have a strong database. If we don't have database for preoperative radiotherapy in retropattern sarcomas, there are no randomized trials, but yes, that's an option and it is being recommended in guidelines. For oligometastatic disease, which cannot be resected, stereotactic surgery, stereotactic surgery is an option.
Right.
So
Thank
we
you so
have a trial at the moment. I'm trying to answer this question.
Yeah,
whether
sure.
or not oligomets can be served with SBRT. And in that study, the definition of oligomets is quite generous, up to 10 lesions.
Okay, really?
For good or for
Good.
bad
Yeah.
reasons. I won't say more than that, but there is a sarcoma-specific study that's ongoing at the moment.
So this makes the medical oncologist very happy. If you can encompass 10 lesions as oligometastatic, I'm really happy.
Yeah, you know, but
and I have a comment.
The problem is then the 11th lesion appears.
Yeah, you're right.
I have a comment. I have a comment. In our center, we have taken 16 lung mets.
Okay.
16 lung mets.
In one go.
And in one go. And there is a guideline on this. British Sarcoma Society recommends that sequential metastectomies, they are also there, evidence-based, that the 11th comes, we take it out. The 12th comes, we'll take it out. If it is reasonable to take it out. And if there's something which you can't go for surgery, stereotactic radiotherapy may benefit. But again, we don't have a database, but in patient who has a long survival, it do work.
Yeah, I agree. And as Razak was already telling us that our case patient had systemic disease, but the thing is that we don't have anything to offer them. I mean, we are very thankful to our surgeons that they help us a lot and they take out all the lesions again and again and again. And yeah, your opinion and your advice is very valid that we should look at our data and see how many patients were successfully treated in this way. So, Dr. Masood, last question from my side. What do you do with the patients who come with biopsy scars which are against the skin creases, horizontal on the arm or diagonal, and how do you treat them then? This is a very common thing.
That's a very common scenario. जी बिल्कुल हमारे यहाँ भी यही है. Patients come with diagonal scars on the thighs, so they have to be excised in an elliptical fashion, right? So you encase all the diagonal scar, the length of it, and you manage an ellipse or eclipse around it, oval-shaped scar, and then you excise. Depending on the depth, so you go muscle deep or skin deep or fascia deep. That is determined by the pre-op MRI, but we certainly see a lot of them operated, especially by general surgeons, sometimes, but also by general orthopedic surgeons. That
Dr.
is a major
Ilyas?
issue.
Yeah, that's a real problem. More often is that the biopsy scar is placed in such a way that it makes the whole procedure very difficult. Like you have to go through the medial side, mostly in the distal femur, and you have a big scar on the lateral side. So if you want to excise that one out, and then what to do? So there's so many problems. There was a very good slide shown by Dr. Masood Umar of the proximal tibia, in which he had taken out the skin scar with the normal surrounding skin in an elliptical incision. I think that's what mostly we do. But it's true that causes a lot of problems by placing a wrong scar. Makes it very difficult for the surgeon who does the definite surgery. Yeah. However, you
Thank you.
manage somehow. Yeah. Now, you want to close the session, or
Yeah.
we have still time? I think no.
Yeah,
I
I
had a
think,
question.
yeah, sure. Go ahead,
I had a
please.
question because there's so many experts and so many great people around in their fields now. I had a question. I wonder. We discuss it often, me and Dr. Kashif, many times. That these indeterminate nodules that you have in the lungs at the time of presentation of the patient, and we tell them there is nothing in the lung, and we treat them as a non-metastatic tumor, and we go ahead with the definite surgery. But then later on they develop, but sometimes they don't develop. So I was wondering if we offer something for these patients as a neoadjuvant chemo or something like that, for the indeterminate nodules that are seen in the lungs.
On the CT scan, I
On
would
the
ask
CT.
Razak and Abbas, what is your take on that?
We infrequently do this. We usually accept that there is a number of patients that will fail treatment. But if you think the index of suspicion is reasonably high, it's not unreasonable to say, why don't we give you some neoadjuvant treatment? Okay. Regardless what the treatment is, either chemo or radiation to the primary disease, and then let the subsequent scan show whether they've got metastatic disease. Now, the approach is slightly different because for us, our surgical time, our surgical availability is probably the most rate limiting.
Okay.
Our surgeons are enthusiastic, but their time commitment is not as available. So sometimes we use this strategy. Now, given that in your institution, the surgical commitment is very quick and very, they're very responsive to removing the tumor, then I think you will always have the problem, which one do you do first? So for us, when the index of suspicion is high, we do give neoadjuvant chemotherapy to see whether they declare itself. But many a time when they're just small, like this 1 or 2 millimeters, we actually go ahead and give them the benefit of doubt. Now, one of the areas that's going to be very interesting is where liquid biopsies come in to look whether or not you can detect there is evidence of circulating tumor DNA. And I think as that technology evolves over time, becomes cheaper over time, and becomes more available, I think that will help us a lot to determine whether we should just go on with surgery or give something to the patients beforehand.
Agreed. Totally agree. We do not have the option of liquid biopsies here, but as you say, once they become a little cheaper, I think they will help us with these difficult situations. Abbas, do you agree?
Yes. Once the patient has a disease in the lungs, and we are definitely sure that this is the disease in the lungs, then probably it's already over. So whenever there is a doubt, the benefit of doubt should be given to the patient, and the setting should be made curative, and the intention of therapy should be made curative whenever possible. And we should try our best that if there is any indeterminate nodules, we should consider it probably it's not there, and we should offer curative therapy and follow that nodule over the time, and if it develops into, it may or may not develop accordingly, according to the guidelines.
Thank you. Thank you. Point well taken. Any other comment? So with this, we come to the end of our session. I would like to thank all of you for your precious time and expertise.